Thanks. Thank you guys for coming. My name is Nilika Singhal. It's nice to see you all. Feel free to shout out questions as we talk. It's pretty informal, and hopefully other folks will trickle in, but if not, you get all the knowledge. Oh boy, well he must be, no contest, understood. So I work at University of California, San Francisco, and I'm here to tell you guys about an exciting new project that I'm participating in, collaborating with other hospitals across the country to create what we're calling a learning healthcare system for pediatric epilepsy. So welcome, and feel free to shout out questions as we go. So the idea of a learning healthcare system is not one that we have invented on our own. And actually, in our field in pediatric epilepsy, we are basing our learning healthcare system on one that already exists that's called the Improve Care Now Network. Now, this is for a whole other type of condition altogether, but this is basically a collaborative care network in the world of something else called inflammatory bowel disease. So my colleagues in pediatric gastroenterology work within this framework of a learning healthcare system that's really improved the care of their kids. And what they do and what we hope to emulate is using quality improvement tools and methodology to really advance our field, and to use you guys, to use our patients and patient families as the drivers of change to improve the care that we provide to your children. So looking at a graph from this Improve Care Now network, which again is not for us in neurology, but this is what our colleagues in GI have been doing. By implementing this type of learning healthcare system, you can see across the bottom axis as the years go by, the rates of remission for this other GI condition have really skyrocketed from the 60s to 70s to closer to above 80%. And we're seeing that the more that we can work with our patients and with our families in a much more collaborative way, the better our outcomes will be. So to back up a little bit, what is a learning healthcare system? What does that term mean? What we hope to do, so this is basically using quality improvement tools and methodology in real time, in real life, to help improve the type of care that we're delivering to kids with epilepsy. So learning healthcare systems have leaders who are committed to this culture of continuous learning and improvement. We systematically gather and apply evidence in real time to help guide our care. So basically we're using evidence to show some light into what our blind spots are in the work that we do in taking care of your kids. We are using IT information technology methods to share new evidence with clinicians and with families to improve real-time decision making. We definitely promote the inclusion of patients as vital members of this team, and then we capture and analyze data and care experiences and use these continuous feedback cycles to let our hospitals know what we're doing well and what we need to improve on. So let me tell you a little bit about the learning healthcare system that we've set up, where we are, and what the future steps will be. So basically, you can see on the left-hand side of this slide, we've got all these different sites. So those are all the different hospitals that we hope to connect together across the country to create this learning healthcare system. It's going from site 1 to site N. So far, we've got about 20 hospitals that are connected in this network so far. And all of us, as you've noticed in the last few years, have been adopting these electronic healthcare systems. So now when you see your doctor, instead of a clipboard and a pen, they're stuck behind a computer screen taking all these notes as you type. What we hope to do is use that in a smarter way. Like basically right now, all these electronic systems exist for billing and coding, which doesn't help our patients at all. But we want to actually harness the power of this electronic healthcare system to actually improve the care for our patients. So in my world, in pediatric epilepsy, I take care of a lot of kids who have really rare conditions, rare genetic diseases that at our hospital in San Francisco, we might have just a handful of kids with that particular genetic mutation. But when we collaborate across the country, we'll have dozens or even hundreds of kids with the same conditions. And so collectively, we definitely need to use our electronic healthcare system, our record, in a much smarter way to get more information, more data about our kids with more rare conditions. So at the point of care, which is when you're sitting down with your doctor, what we hope to do is change the way the doctor and you guys are talking about pediatric epilepsy, change what information we're gathering at that moment that you're face to face, and including that in a smarter way in the electronic health record so that we can go back and look at that and compare hospital to hospital and system to system across the country. And then what we hope to do with that information is look at the quality of care that we're delivering. So how is UCSF doing compared to Seattle Children's, compared to UCLA, compared to Hopkins, compared to Harvard, compared to Cincinnati, and look at what the data show, and then feed that information back regularly, so that we're not doing some research study that's going to take 7 years to get published, but periodically, every so often, look at what we're doing in real time and give that information back to our clinicians so that we can change our practice in the moment. So this is a slide looking at one example of what kind of information we were going to harness from our electronic health record. So this is an individual kid. The top box looks at the diagnosis, and then after that looks at the inpatient stay, the third box is the medications given, and then the last box is outpatient. So from the health record, we can pull all this data. There's no additional manpower that your doctor has to put in to look through that chart to get that. The computer system can pull that really quickly for us. So we can look at diagnosis and then what the delay was before starting treatment. With infantile spasms, this is in our world an urgent condition that's almost like a medical emergency that we need to treat right away. Every day matters. And so we can look at this information and feed it back to our doctors in real time. Everybody knows that it's an urgent condition, but is our hospital system good at supporting our patients? Are we getting the med in hand and giving it to our kids in a fast time frame? So we can pull all these ICD-9 codes that typically are just used for billing and coding, but actually use them to improve the care that we're giving to our patients. I talked a little bit about what we want to do at the point of care. So what that means is when your doctor is sitting with you in clinic and they're typing in the chart, most of us in pediatric epilepsy are asking the same questions, like how often are the seizures? How bad are the seizures? Do you give a rescue med? Have you been to the ER? You're supposed to bring your papered seizure diary so we can look back month by month, like what's been the trajectory of seizures. But we are working on creating this kind of what's called a smart form. At our hospital, we use this type of system called EPIC, but another electronic health record is called Cerner, and there's a few others that are largely used across the country, and these types of smart forms are creatable across the board so that your doctor can click through and include the data that we're wanting to include at that moment. And so then later when we're looking in the next few months to collect these information, it's already all there. The types of questions that we want to include in the smart form are seizure frequency of all different types of seizures, quality of life, like what the seizure impact has on your daily routines, or what the medication side effect, how that impacts your daily routines. The reason for the epilepsy, do we know the cause of the seizures or not? Do we know what kinds of treatments are useful or not? And then at the bottom, even process measures, like are we talking with our families about mental health that might be issues with our children that are under-recognized and under-discussed? Are we talking about life and death situations where we're preventing the catastrophic seizure event as much as possible, or at least having that conversation with our families? Are we talking about pregnancy counseling for teenagers and younger adults? Are we talking about driving risks with our teenagers, and so capturing those types of quality of life impacts as well at the particular ages? So these are the types of data that we want to make sure in our smart form that our doctors are including in our conversations with our kids. And so this is one of the types of questions that we want to include. So thinking about your child's usual routines, how often in the past couple of weeks have seizures really changed, significantly changed those routines, and we'll select which one applies. Thinking about your child's usual routines, how often in the past couple of weeks have seizure medication side effects really changed your child's routines, and we'll click through the appropriate answer. A lot of these things we hope to glean in our conversations with families, but it's not really well captured in the health record, and so that's where the smart form will come to play. Yeah.
Is there going to be anything for family input so that they can have information or anything like that?
Family input so that what? Say it again?
So they can have like a seizure log or something that will have to be a part of the system?
Absolutely, yeah. So the seizure diary should be able to be included in the system in a really efficient way. There are a number of electronic seizure tracking platforms and apps already in existence, and so we hope to partner with those groups to pull that in more automatically. So far, our Learning Healthcare System group has come up with 5 different projects that we're starting to lay the groundwork for. And the first three projects were kind of lumping into quality improvement projects, and the bottom two were lumping into this category of comparative effectiveness research. So these are the initial reasons of why we're building this network and why we hope to use a health record differently. So the first project, first line therapy for infantile spasms. Everybody knows what we're supposed to be doing, but are we actually doing it well? The timely treatment for status epilepticus. Again, everybody knows that this is a seizure emergency, but how good is our hospital at actually treating that in a quick fashion? Referral of treatment-resistant epilepsy for comprehensive evaluation. So the talk just before me was really focused on comprehensive evaluation. So all the different types of brain pictures and scans and testing that comes together with a comprehensive evaluation. Sometimes we find that there's a delay between getting your regular doctor to get you to that step for the comprehensive evaluation. So is that happening in a timely fashion? And then the bottom two projects that we're going to work on, you guys might have heard of something called therapeutic hypothermia, and what this basically is after some bad brain injury, like if there's an event that leads to lack of blood flow and oxygen to the brain, such as sometimes happens during a difficult delivery, for instance, what we actually prescribe is cooling. So hypothermia to newborn babies can prevent this cascade of ongoing brain injury when there's already been an event. So this is already standard of care when a baby has a difficult delivery. If we're worried about that baby, we do this therapeutic hypothermia. That's already given. But what's unknown is if we should do full body cooling or just cool the head. And different hospitals practice different ways, and there's not a gold standard for this. And so we hope to look at that, like what's currently being done and which truly is the better option. It shouldn't be just up to the whim of whatever doctor is there that day and what their personal experience is. And then lastly, one of our initial 5 projects is if we have a child with a brand new focal seizure, there are these 2 meds that are commonly used. Keppra or Trileptal are some of the most commonly used medications for focal seizures. And a lot of that, again, is based on personal experience. But when you look at thousands of kids, is there really one that's better than the other? And we hope to finally answer that question so we can put it to bed a little bit. So those are initial projects that we've come up with. And some of it's based on the gaps in the care that we currently provide, aka our blind spots, like what we don't know that we're missing in the care of pediatric epilepsy. So I have a couple slides that shed some information on the blind spots or the gaps in care. This paper was looking at the treatment of status epilepticus, which is prolonged seizures that don't stop on their own, at 9 different hospital centers, and looking at how long it takes to actually get the med in. So the type of anti-epileptic drug you can see on the column on the left. So we have our first benzodiazepine, first non-benzodiazepine anti-epileptic drug, second non-benzodiazepine anti-epileptic drug, and then continuous infusion if that's what it takes to stop the seizure. And we know what's recommended. We know that the first one should go in just a couple of minutes, 5 to 10 minutes, and then 10 to 20 minutes, etc. But in reality, there are these longer delays, and so the median, like the middle time of getting those meds in at each of these centers, is much longer than what would be recommended. So this is like really spotlighting what happens in reality. And then from here, we can go on to say, listen, hospital A, you know you're supposed to give that medicine within 5 to 10 minutes, but you're averaging at 30 minutes. So what's the reason for that? There could be 10,000 reasons, like, we need 2 nurses to sign off from the pharmacy, or we need the medication in the emergency room instead of in the pharmacy, or we need, some kind of seizure alert protocol so that when there's a status patient, it gets triaged differently in the ER. There's so many different possible solutions, but the first step is taking a little bit of an introspective look and identifying that it's a problem at our hospital in the first place. And so we hope to improve the time to treatment of status epilepticus by allowing ourselves to compare how we do to our friends and colleagues across the country. We have a ton of literature, just paper after paper, for the treatment of infantile spasms to show that either oral steroids like prednisone or ACTH, which is an injected type of hormone treatment, or this other seizure medicine, vigabatrin, are like the gold standard treatments of choice for treating infantile spasms. We have tons of papers. I mean, this is only 3, but there's probably 24 to show that that's what we need to be doing. But a group of us looked at the current treatment of infantile spasms, and this is among mostly academic medical centers. So us in the ivory towers, we always think that we're, up to speed on the current standard of care. But when we look at academic medical centers, we still find that a large number, like maybe 1 in 7 kids, is getting something that's not ACTH or oral steroids or vigabatrin. So we're getting topiramate or some other medication, and 1 in 7 is not good enough for us. We need to make sure that 100% of the time we're treating kids with the appropriate treatments from the get-go. So this is another kind of spotlight into one of the current gaps in the care that we're providing. We as a collective, group of clinicians taking care of kids with pediatric epilepsy. And then, this highlights the same information again. So kids treated with something that's not ACTH or oral steroids or vigabatrin, which is 1 in 7 kids in this paper, aren't getting the gold standard treatment of choice. So we hope to be able to have more of these spotlights across the board in pediatric epilepsy so that we all are giving the same. If you go to a hospital in California versus on the East Coast, you should be getting the same treatment in this country. And so we hope to really bring our care up to speed. Okay, this paper was really shocking to me, but I felt like I want to share it with you guys because you're going to be our champions and our change agents in what we're doing in pediatric epilepsy. So this paper was really clever. There's a social worker who did this study all by herself, and what she did was called a bunch of clinics to schedule appointments for children. So this was like a sham phone call. She would fake it, basically. She called a bunch of different clinics. You can see across the bottom, orthopedics, psychiatry, asthma, neurology, endocrine, ENT, and dermatology, just to schedule an appointment for her child. And she would say for half the calls that they had public insurance and for half the calls that they had private insurance. And universally, the dark blue lines are when she said that she had private insurance for her family, those appointments were given more quickly compared to if she said that she had public insurance. And us in urology, we're no better. So among 89 clinics that accepted both insurance types, the average wait time for public enrollees was on average 22 days longer than the wait time for privately insured children. And this to me was shocking and extremely disgusting and sickening and disappointing, but again, we won't know unless we look at this. And so this is one of our blind spots, that this is happening from no one's bad intention, but there's some systematic forces at play here. Like, why do our clinics preferentially schedule kids with private insurance faster? It's unacceptable. And so we cannot change it unless we know that it's happening. So this was really an important paper for me to read and to be aware of as well. That's just singling out in neurology, we did no better. So this is my last slide, and then I'd like to open it up for comments for you guys, but the concept of creating our learning healthcare system has a lot of legal, ethical, and financial implications, and so that infrastructure is being developed. We are grant supported, so we have some NIH funding to pay for things like enlisting our information technology departments, our IT, to run these data audits, and we're starting with quarterly. So I think that so far we're actually up to 15 centers, not just 13, to have all these data use agreements in place, service agreements, and subcontracts to make sure that the IT infrastructure can keep going. Next is the technical infrastructure. So we are developing the smart form that we would ask our individual IT departments at each hospital to have available in Epic or in Cerner or whatever healthcare system we're using, and then to generate quarterly reports. And so those quarterly reports have already started, where we started earlier this year, where we can every quarter take a look to see what meds we're giving, how kids are doing, collecting these data and getting that kind of groundwork moving. We hope in 2020 to have 20 centers by the end of 2020, and to keep building. This is like a 7 to 10 year project that we're just starting now. When we have that smart form built, we'll be able to look at the treatment for infantile spasms, for status epilepticus, for cooling, what kind of cooling treatments are being administered, et cetera, et cetera. And then to really report out our quality measurement reporting, comparative effectiveness research as time goes on, to see the outcomes looking at the different treatment algorithms and how kids are doing. And then the future state, we hope that this is so far very broad strokes. We hadn't even gotten into the specifics about genetic conditions or EEG findings or imaging findings, and looking to see what where the differences are and how our hospitals measure up. But that's sort of our future state. So we hope that as we build this infrastructure, it'll continue to grow, and that we can get even more granular in the next 10 to 15 years. So I think that's the last slide that I had. Thank you guys for your attention. I'd be happy to take any questions that you might have. It's kind of a short talk, and I left a bunch of time at the end to be able to field questions, but thanks for your attention. Yeah.
What hospitals are currently participating? You said you have about between 13 and
Yeah, so the main site that's coordinating all of this is Cornell in New York, and us in San Francisco at UCSF, and there are a smattering, which I have the list on my computer and I can share with you, but it's predominantly for now coastal city hospitals, so I know Seattle, Stanford, UCLA, us, Cornell, Hopkins, Columbia, CHOP, and I'm forgetting others, but it's the beginning, and somehow it seems to have started on the coasts, and we hope to continue to progress. Mm-hmm. So I would ask, I have a question, I have an ask for all you guys. Everybody has come from different places and are gathered here at this wonderful resort for this meeting, but when you go back to your doctors, you can ask about the learning healthcare system and if they're participating and what else they can do to move the ball, and you can spread the word also. We hope that the more folks are aware of this, that the more hospitals will be motivated to include this. It seems daunting to link all these differing systems, but it's not actually been that daunting. It's sort of like a formula, and our IT groups know how to pull data and know how to generate reports, and so it's a little bit of just about lighting that fire under the clinician to get the ball moving on it. Yeah.
How could we go about telling and asking our doctors to start online?
So I actually have an informational pamphlet. It's online, and so I can email out the links afterwards if that's helpful. But it's called the Pediatric Epilepsy Learning Healthcare System. That's it. And we don't have another fancy name yet, but I hope that we, like I was saying, whoever's using an electronic health record can participate. That's like the minimum requirement with which most systems are using in this day and age. So the coordinating sites ourselves in Cornell have been reaching out to large pediatric epilepsy centers to invite them to, but there have been other systems to approach us as well to say that they'd like to be included. I should also mention that there already is a network of maybe it's up to 70 or so pediatric epilepsy systems across the country called PERC, the Pediatric Epilepsy Research Consortium, PERC, and that group regularly meets at our national meetings and talks about projects and talks about how we care for kids. So most of the hospitals that are joining the learning healthcare system are already part of this PERC umbrella, but those would be the two things to ask your doctor about. Are you a member of PERC? Does your hospital and then are you participating in the learning healthcare system? Those are just the two questions, and they know how to find us by looking at our website.
Besides doing that, is there anything as patients and families that we can assist our doctors in assisting with something like this?
I think that's the main thing, is getting the awareness out and making sure that your doctor knows it's important to you. Because that's where it's coming from. It's like our kids are teaching us that we have these blind spots and that we need to make sure our standard of care is as consistent as it can be across the board. But from the doctor's end, the PERC, our infrastructure is there. We have research assistants and coordinators ready to help doctors who want to take this on at their site. The biggest thing is setting it up in the beginning, like getting the data use agreements ironed out between the IT groups from Cornell or from us to the local hospital. But we've got everything templated. They just have to get people to sign it. So it's actually not that challenging. But if you would ask, if you could just say, listen, it'd be great for you to participate in the learning healthcare system. Are you a member of PERC, or have you heard of that before, and kind of spread the word. We actually in December have our annual American Epilepsy Society meeting and have a few opportunities there to connect with other physicians and researchers across the country. So we hope to spread the word even more at that meeting coming up. It's in Baltimore next month. Well, thank you guys. I'm around, I'm here, so if you have other questions about this or anything else, feel free to let me know what I can do to be of help. Thank you.